any blunt trauma or a fall and outstretched hand with an injury to any of these things. And of course, if there's an ulnar nerve injury and some surgery is done under the elbow, always keep it in mind, it could be an iatrogenic. So this history will probably tell us where the nerve is injured and what could be the type of injury. Like a friction neuritis because of cubitus valgus, it is some sort of an axonatomesis, or it could be at the most late neuropraxia. Whereas a penetrating a stab wound along the course of the nerve, always, unless proved otherwise, it will be a cut injury. So your diagnosis of axonatomesis or neuropraxia can be made out from the history to a certain extent. So you need to take a detailed history. Now, the other cause, I told you this is what is the fluxion. Suppose the patient says that he has developed this deformity for a long period of time, then you need to see, look at the elbow and see whether, ask the patient in the history, whether the deformity at the elbow was progressive in nature or it's been static. A progressive deformity at the elbow, obviously, it's the late nerve palsy, that is cardiac palsy. Then you need to examine a little more in detail about around the elbow region also, in addition to examining the nerve. The third thing is compression. Now, compression is not very common as median nerve in the carpal tunnel syndrome, but in arthritic patients, rheumatoid arthritis patients, if they have an arthritis of the elbow, the osteophytes can cause a cubital tunnel syndrome and produce. So if no other cause is found in the history, you ask for the history of arthritis and the patient has got an arthritis, it could be a compressive neuropathy around the elbow. And of course, last common thing in our country is Hansen's. If no trauma or none of the above causes are found in the history, ask the patient indirectly whether he has any medication history in the past and ask him if he has got any white patches in the body. Because most of the time, patients would like to conceal these factors, especially in a severe deformity, and then more than one nerve is involved. So obviously, suspect Hansen's, unless proved otherwise by the history with this. So with this detailed history, we will be able to make out whether it's a traumatic lesion or whether it's a lesion because of a disease. So this is the first part of it. So history itself will tell us whether it's trauma or a disease, and history to a certain extent will tell us where the lesion is and probably what could be the type of lesion. So three of the answers you get it by taking a good detailed history. The next is the ulnar nerve examination. This is a standard protocol what I follow for every peripheral nerve. You start with attitude, then you have a motor and sensory evaluation to know the level of lesion, to know the type of lesion, and to plan for reconstruction. 3T Tinel sign to know again the type of lesion and also to prognosis. Now I'll go into little detail in about these three things. Now coming to the attitude of deformity, as I told you, the claw hand. If the examiner asks what's the deformity, you have to tell it's a claw deformity, and you need to exactly define what it is. People say extension at metacarpophalangeal joint and flexion at IP joint. It is actually hyperextension at metacarpophalangeal joint and flexion at joint. Some examiners insist on asking you to demonstrate the claw hand. This is the correct way to demonstrate the claw hand. Sorry. This is the correct way. You keep both the hands together, hold the wrist, and ask the patient to extend all the fingers. As you can see in the left hand, again ask the patient to flex it and extend it. So if examiner asks you to demonstrate this patient as a claw hand, I would request put both the hands together, and this is the simplest and the easiest way to show that this patient has a clawing of ring and little finger on the left side, whereas the right side it is normal. Then next is your motor and sensory evaluation. So before you go for motor and sensory evaluation, you need to know the muscle supplied by these things. I'm not going to go into the details, but what you need to is the ulnar nerve does not supply any muscle in the arm. And in the forearm, it supplies only FCU and FDP of ring and little finger and below the stick. Among the group of muscles, when you want to do a motor evaluation, you can examine FCU, you can examine FDP, you can examine hypothenar all as one group. Individually, it is difficult. Maybe you can examine the flexor little finger, and then you need to examine the intrinsics. So this is the standard So this is, I'm not going to go into detail. This is a standard evaluation of the muscle power. We all know grade 1 to grade 5. So always when you examine, don't say there's a flicker of contraction, there's some jog of movement. Make it very clear. There's a flicker of contraction, you say grade 1. So be very clear in what the grade is. You cannot say 3 to 4. Don't have in between. You have one grade, whichever it is. And what's important is now once you have given the muscle power chart to the examiner may ask you to demonstrate one Sorry. Now, the first one of the easiest muscle, if they ask to examine, is your flexor carpi ulnaris. So, what we need to understand is flexor carpi ulnaris, ulnar deviates the wrist and then flexes the wrist. So, if you want to examine the flexor carpi ulnaris, the correct way is you ask the patient, you do ulnar deviation of the wrist and ask the patient to flex it. Sorry, I think there is some problem with this video. This is the corrective. So if the examiner asks to demonstrate, you should tell the patient to ulnar deviate the wrist and flex it. And after that, ask the patient to hold it in that position, and you try to apply pressure to deform the movement, what he has got it, to cover the grade. So this is important for flexor carpi ulnaris. The next muscle, if we are asked to demonstrate, you can... one second. If like FDP, the easiest way to do FDP is you stabilize the PAP joint and ask the patient to flex the only interphalangeal joint. So this is the correct way to do FDP. Then next muscle which you can among the hypothenar, one muscle you can tell is an abductor distal minima. Again, an abductor distal minima is an abductor of the little finger. So the correct way to check is you ask the patient, keep the patient palm flat on the table and ask them to abduct the little finger. So it's always safer to put it flat on the table so that it becomes easy. Now, the next muscle is your intrinsics. Again, intrinsics are abductors and adductors in relation to mid finger. So you can ask the patient to keep the pan flat on the table, again with the dorsum facing the examiner, and ask the patient to flex and abduct and adduct the fingers. So these are the four muscle groups which you can examine ulnar nerve. Individually examining the other muscles is different. Of course, you can also examine the adductor policies, which I'll tell you when you go for the special test. So this is how you examine the muscle power. So if the examiner asks to show one muscle, you can choose any one of the muscles and show it to him how you have examined. Or if the examiner insists that this particular muscle to be demonstrated, you should be able to do that. The next is once you have done that, then you go for a sensory evaluation. This is a standard. We all know 1.5 fingers of the little and half of ring finger is supplied by ulnar nerve. But what is more important is always in the exam, please carry a cotton wasp and a needle to check the thing. A lot of the times the students say they have checked, and when they are asked to demonstrate, they'll be searching for the needle. So the examiner knows that they have not done the examination and they're telling it blindly. So please carry a disposable needle and a cotton wasp with you. These two basic examination needs to be done. You don't need to go beyond a 2-point discrimination, thermal sensation. At least pin prick and a soft touch needs to be examined in the exam. Then once, more importantly, if the examiner asks what is the autonomous zone, it is the terminal phalanx of the little finger. To a certain extent, the middle phalanx of the little finger is autonomic zone. So if the examiner asks you to show the sensory evaluation, you should first check in this autonomic zone and not in the ring finger. Now, once this is done, there are a lot of different tests are given for claw hand. There are about 10 tests are given. So you don't need to know all those things, except sometimes the examiner will ask, do you know any one of them? Either you can say yes or no, but nobody is going to fail you because you don't know all these tests. But certain tests which are very popular with the examiner is Wattenberg's test, which is nothing but an overall action of the long extensor will deviate the little finger away. So the little finger will be always to the side. This one sign you should know. And cross finger tests to test whether intrinsics are working or not. Fromet sign and card test. These four you must be knowing. Rest of the things, it's a choice. If you know it's good, if it doesn't know also, it doesn't matter. Now coming to the Fromet sign, you know this is because of the adductor paralysis. When the patient tries to hold a book instead of adductor, the FPL acts, and everybody knows this. You should be able to demonstrate. So always when you want to demonstrate the Fromet sign, use a hard book. Don't use a soft book or a paper because it will never demonstrate. So always use a hard book or a hard cardboard, so that it doesn't yield. Then only you will be able to demonstrate. So that's one point you need to keep in mind. Next is card test. There's a little controversy. Some people say the patient himself put the card in the similar fingers on either side and pull and see. Probably that is the best way. But even if you do this way, most of the times the examiners will accept it. And the other easiest way is the cross fingers test, which is the simplest test. Is just ask the patient to cross. That means the intrinsics are working for both the fingers. So these four special tests you should do, and if the examiner may ask to demonstrate one, you should be able to do that. Then in all ulnar nerve lesions, irrespective of the clear history of trauma also, it's mandatory that you need to examine all the peripheral nerves. The examiner asks whether you have asked the peripheral nerves, I have examined all the peripheral nerves. Sometimes the examiner asks what are the peripheral nerves that are palpable. So peripheral nerves that are palpable are which are against a bony background, that is supraorbital, cervical, ulnar, median or the distal end of radius, dorsal cutaneous of the pedis, sometimes on the radius, or posterior tibial behind the medial malleus, the calcaneum, and lateral popliteal to the neck. But usually we palpate behind the elbow and lateral popliteal nerve. And sometimes the examiner may ask you to demonstrate how you palpated the ulnar nerve. The correct way is abduct the shoulder, flex the elbow to about 120 degrees, put your fingers behind the middle epicondyle, with the other hand holding the wrist level, forearm at the wrist level in mid-prone. Try to roll the nerve and feel for it. So when you part the ulnar nerve, you should feel whether it is thickened or not, and what is the consistency, whether it's firm or soft, three, whether it's tender or not. Just saying ulnar nerve is palpable is not correct because every ulnar nerve is palpable. But palpable ulnar nerve is normal or abnormal is what you are finding, which is examiner interest. So you should comment on the thickness, you should comment on the consistency, and you should comment on it whether it is painful or not. This is again very important. A lot of the time the students say the ulnar nerve is palpable. That is because everybody ulnar nerve is palpable. But whether in this case the palpable ulnar nerve is normal or abnormal is what we need to inform for the examination. So in all ulnar nerve lesions, irrespective of the injury, please make it a point that palpate other peripheral nerves and see. Sometimes the senior examiners always insist that every ulnar nerve in lesion you must palpate all the peripheral. So don't take chance. Now, once you have done the clinical examination, you sit down and you chart out all your muscles. Then you have to localize where the lesion is. So the localized lesion is very easy. If all the muscles applied by the ulnar nerve are paralyzed, like FDP, FCU, hypothenar, intrinsic, it's a high nerve palsy. If FDP and FCU are spared and only hypothenar and intrinsics are paralyzed, that's a low nerve palsy. That is the level at the wrist level. So this is very easy. So by charting your muscle power, you can easily localize the region. One question in the localization which usually the examiner asks is what is ulnar paradox? So normally when the lesion is higher, like in a radial nerve, you will have a wrist drop and a finger drop. Whereas the lesion is at a lower level, like at the posterior palsy, you get only finger drop. So normally what happens, the lesion is higher, the deformity is more. The lesion is lower, the deformity is less. In ulnar nerve, it is opposite. The lesion is higher, the deformity is less. The lesion is lower, the deformity is more. So it is opposite of normal. So that's why it is called an ulnar paradox. Now it is called, why this happens is, for a claw hand to develop, in addition to paralysis of the intrinsics, you need to have long flexors working. Long flexors of the little and finger are not working. In high lesion palsy, the deforming force is not there, so the deformity will be less. So this we should be able to explain, and we should be able to give a logic reasoning why this happens. This is very important. And once another thing is a tardial ulnar nerve palsy, another question usually asked. Tardial ulnar nerve palsy, the definition is you should be able to tell ulnar nerve palsy developing over a long period of time because of a progressive deformity leading to stretch and friction neuritis of the ulnar nerve. If they ask you what is the cause in tardial ulnar nerve palsy, it is a friction neuritis because of abnormal angulation at the elbow. That is the reason why that's why the friction neuritis develops over a period of time, and then they'll have strong Tinels behind the elbow with which you will be able to diagnose. Now, coming to the Tinel sign, the third part of it is to know whether the nerve is recurring or not. Now, whenever you want to elicit the Tinel sign, you are supposed to tap along the course of the nerve from distal to proximal. Now, if you don't tap on the nerve and tap on the side of the nerve, your Tinels will be always negative. So usually I, as examiner, I usually ask them, go back to the anatomy and tell them, draw the surface anatomy of the ulnar nerve. So that once you draw the surface anatomy, then you will tap on that. So most of the students, they don't know or they don't read the surface anatomy in peripheral nerve injuries. So for ulnar nerve, the surface anatomy is from the anterior axillary fold to the middle of the arm, one line. From the middle of the arm, medial side of the middle of the arm to behind the medial epicondyle is another line. From behind medial epicondyle to the pisiform bone is the third line. So we draw these three lines, that is the course of ulnar nerve, and you are supposed to check the Tinel on this line only. If I find a student who has drawn a surface marking of ulnar nerve, without even asking a question, I would pass him because he knows where to. Otherwise, Tinels is a specific sign where you need to tap over the wrist. So a lot of the times when we ask the student about the surface anatomy, they don't answer. So I request all the students, the three peripheral nerves, you must know the surface anatomy. You should be able to draw the nerve on the skin. Now, whether this Tinel sign, as Vinita has said, it's not of much help. I do agree it's not of much help. Now, they ask, you need to do 2 subsequent times to help that, to know whether the Tinels is not. So these are the possibilities that I said. If the Tinels is positive at the suspected site of lesion and there is negative distally, that means there is no recovery. The Tinel is positive at the lesion and also positive distally. That means some recovery is occurring, so you can wait and watch. The Tinel is negative at the site of lesion and positive distally. That means it's fully recovery has happened. So this can be known only when you do two subsequent examinations. But even in one examination, when you do check the Tinels, if the Tinels is at the site of injury, then it may or may not recover. If the Tinels is distal to the site of injury, there is a possibility of recovery. So some prediction can be made even with a single Tinel. Now, once this is done, then the final diagnosis, now it is easy. Now you put in the final diagnosis, high or low ulnar or palsy due to penetrating injury around the elbow of 2 months duration, not recovering. So that will be the complete diagnosis. Now, once you've made a diagnosis, then the discussion starts. That is what you want to do. So most of the times the discussion starts with investigations. So what students need to understand is there's no specific laboratory indications which helps us. When we ask investigations, a lot of students, they start with CBP and ESR. Please don't answer that thing because CBP and ESR is for surgery, not for knowing the recovery of the nerve. So imaging studies, again, there are no imaging studies which help in nerve lesions except for brachial plexus. The only thing which helps is EMG. So EMG, again, if the examiner asks, EMG around 4 weeks only it will help us to know whether there's a fibrillation potential is there or denervation or reinnervation. Earlier than 4 weeks, EMG also does not help us. And then coming to nerve conduction studies, in neurotemesis and axonotemesis, nerve conduction studies are not useful. When you suspect a compression neuropathy around the elbow or a tardial ulnar nerve palsy, probably a delay in conduction, a nerve conduction study will help. Otherwise, in a traumatic nerve injury, probably nerve conduction studies do not help us. And treatment, when it comes to treatment, as Lalit sir has said, first thing we need to is you don't jump. First thing is whenever you see a nerve case, when you're planning for surgery, to prevent the patient developing a fixed contracture, you need to give a splint. So the principle of the splinting in ulnar nerve is we need to get flexion at the metacarpophalangeal joint. The metacarpophalangeal joints are otherwise called as knuckles. That's why the splint which is designed for claw hand is knuckle bender splint. That is, it bends the knuckles. That's why it's called the knuckle blender splint. It can be a static splint involving the 4 fingers, or if you're a Hansen's patient, he's under treatment and you want to wait for 3 months, you can give a dynamic splint where the other muscles which are not involved are not put to disuse. Then once this is done, then depending upon your diagnosis, your treatment options are there. If it's a cut injury, then now up to 9 months, we always advise to go for an exploration and do an appropriate repair. I will not go into this. The answer should be exploration and repair. Sometimes the examiner asks what is the current outcome of ulnar nerve repair compared to radial nerve or medial nerve. Ulnar nerve repair outcomes are reasonably bad, especially the recovery of the intrinsics, because the muscles are small and they die early. So you must always tell that ulnar nerve recovery prognosis is bad, so you must be mentally prepared for reconstruction to be explained to the patient. Then if it's a tardial ulnar nerve palsy because of friction neuritis or a cubital tunnel syndrome, the treatment, your answer for the treatment is anti-transmission, the neurolysis and anti-transmission of the ulnar nerve, which will completely recover the nerve. And if it is a Hansen's or a very old case of ulnar nerve, where you're sure that it's not going to recover, then we need to do a reconstruction. So before you go for reconstruction, usually I ask the student, what is the disability the patient has if he has a claw hand? The usual disability is he has weakness of grasp, especially the large grasp he cannot do, and power grasp is also weak. As you can see here, when he tries to go and hold an apple, there is no flexion of the metacarpophalangeal joint and the object moves away. So this is the big disability. So if you want to do reconstruction in Hansen's, what should we need to do to overcome this disability? If the examiner asks what is the principle of reconstruction, the principle of claw correction surgery is to get a flexion at metacarpophalangeal joint. How you get a flexion metacarpophalangeal joint? There are many procedures. There are skin procedures, there are capsule procedures, there are tendon procedures, there are bony procedures. We don't go into the details in the exam, but the principle you should be able to tell that it is the flexion at the metacarpophalangeal joint which needs to be achieved. Now, how we are going to achieve it? Now, once you get a flexion of the metacarpophalangeal, I can see in this video, this patient had a tendon transfer surgery, and you can see that there is flexion. So there are multiple procedures available for this thing. As I told you in my earlier comment also, you need to know one procedure which you are familiar with, and if the examiner asks to describe, you can either it can be Fowler's procedures, Bunnell's, Brand's, but whatever it is, the examiner wants to know whether you know the principle of the surgery. The principle of claw correction surgery is getting at flexion at metacarpophalangeal joint or preventing hyperextension. So then one of the procedures, if they ask you, you can describe. Even if you don't describe, it's not anything that makes, anything that's bad for you. But if you can describe the procedure a little more, probably you'll add a few more marks. Thank you.
Thank you, Dr. Reddy. It's a very nice, beautifully covered, very nicely explained. All the possible questions that can be asked, answers are given. I think it will be extremely useful for every one of you, for graduates who are watching it. I would like to ask the faculty, Dr. Darshan.
Yes, sir.
Anything you want to add?
No, so it's very precisely, very clearly this thing. Means what exam, you don't need to know more than this. This is sufficient. If they can remember this much, that's great. And always one common thing is what he stressed as well, the same signs. You really don't have to know all the signs. Just 3 or 4 signs is what is most important. And how to define claw deformity, simple basic stuff only is the only thing. How to assess. And majority of these short cases, the examiner is more interested in knowing how do you assess that muscle. Those are things. How do you check that? If you show them, that's much more. They're more than happy than management. Very rarely they reach up to management. Just how demonstrate this and demonstrate that. That's all they want.
Very true. Very, very true. Dr. Sunit?
Yeah, a small query. I think, sir, do you think that in peripheral nerve examination also you need to carry on all those buttons and and because those are differentiated at the final level. An examiner, would you like to penalize a student for that, or you will probably accept in peripheral nerve injuries that the examiner doesn't carry?
No, sir. I think of late I've been to a lot of examiners because what happens is if you don't carry pin and cotton, then they think you're bluffing. That's a basic mandate. It's like carrying a stethoscope for a medical examination. In fact, goniometer, knee hammer, cotton wasp, and a sterile needle. I think these are the 4 basic requirements for an orthopedic PG when he goes to the exam. I always tell them if nothing is there, the pin you keep to your hall ticket number, you take the pin and at least check with that pin. At least that makes some sense if you don't have a needle.
I think I tend to agree with Dr. Reddy in that. They shouldn't be too casual about it.
Yes, sir.
You may not expect them to come with a plumb line, but at least basic things like a cotton wool is not a very difficult thing to carry.
No, not only that, sir. In the exam, they can ask the helpers who are there, the invigilators, that I want a needle like cotton. We will always provide them, and we will also. In fact, one examiner was there with me when the student asked for a cotton needle. He was happy. Okay, this guy is examining the case. He's half mentally prepared that he is going to pass.
Dr. Vinit.
I would like Dr. Lalit Meni sir to comment, sir. Anything need to be added to this examination, sir?
I comment to Lalit, definitely.
Thanks, Dr. Reddy, and thanks for taking up those standard questions. I think since you have already answered them, I can't ask them again. So I will make a comment rather than asking the question. So as for any short case in orthopedic exam, we expect that the diagnosis is made in some sort of a scientific way in which we want to include the anatomy, the pathology, and the etiology. And if it is upper limb, we want the dominance, and we want the student to convey if there is any complication associated, and definitely evaluate the distal neurovascular. So for example, in a median nerve and there is a sore on the tip of the index finger, I would expect that part to be included in the diagnosis because it is one of the complication of the lesion over there. So the same basic things of anatomy, pathology, and etiology in the diagnosis. And the thing I want to ask is the second question now. So you have passed the first question, what is your diagnosis? So after that, the next question always is, why do you say so? So there are various ways of answering that, why do you say so? And at times the student starts with the answer because it is a 6-year-old female child. So what is the right way of answering the supporting of your diagnosis? The second question, why do you say so?
Thanks. In fact, we are making a similar type of presentation for all the 4 peripheral nerves and keep it in the archives of my library in the department. So before the exam, they can rush through these things and then make it easy for us.
So, most of the standard textbooks now suggest that when you have to answer the question of why do you say so, we try to follow the same sequence of history, inspection, palpation, movement, and measurements. So, if there is one particular important thing in the history, like stab by
Sir, your voice is. Sorry, you're muted, sir. Rainy, sir, now it's open.
Sorry, I'll come back again. So, my way of accepting an answer on why do you say so is I again try to see whether the person is answering in a systematic way, meaning that he is trying to bring out positive points of each aspect of his evaluation, meaning history, inspection, palpation, movement, and special test. So anything which is supportive of the fact and the diagnosis, like if it is a sharp cut stab injury on the volar aspect of the wrist joint, in the inspection, palpation, and that particular sequence. Another way of answering the same question could be you could bring out the most important part first. Like the patient has a clawing, which is due to the low ulnar lesion. So you can have these 2 ways of answering. Both are acceptable.
Yeah, that is correct, because some examiners want this way, some examiners want the other way. But some people say you hit the nail on the head. Give the most important point first. Some people want it in the order of inspection, palpation. I think that when you are asking the question, what is your reasons? Either way, it probably, if he says the point, is correct. Sandeep?
Yes, sir. I think wonderful presentation by Dr. Reddy, sir. There's no more questions. But I just want to ask one thing. Sometimes what happens, there are 2 nerve injuries or maybe 3 nerve injuries. Okay, and then now the student is confused. Then which nerve injury to be presented first and how? So can you just shed some light on that, sir? That median bhi ho gayi, ulnar bhi ho gayi. So how to present it?
So normally what we say, sir, as far as possible, we avoid double nerve and triple nerve injuries because it's difficult for the examiner. So even if there is a double nerve injury, I would, like Hansen's case, is there with some amount of median nerve involvement, I will tell the candidate to examine this. There it is very, very clear. We'll say examine the ulnar nerve. Like in a bilateral avascular necrosis of the hip, we'll say examine right hip. So you also examine left hip. Because at a postgraduate level, going beyond 1 nerve, 2 nerve, and double nerve and triple nerve lesions, because the 2 problems, one is evaluation is difficult. Second, reconstruction is all the more difficult because there are a lot of principles involved. When we go as a hand surgery trainee in my exam, we always have double nerve and triple nerve lesions. We never have single nerve lesion. So I had a triple nerve lesion of Hansen's and then I had a lot of problems in my exam, in my hand surgery exam. So as far as possible, we also insist, I mean, whenever I go as an examiner, I always insist to have something very clear because you are trying to evaluate the knowledge and demonstrate the science split. So let's not confuse them with this. So I request all the examiners, when you go, select cases where there is a single nerve.
Okay, sir. Sometimes the student is very intelligent and you want to give him distinction. He has performed very well. And then how will you decide? There are 2 nerve injuries and you have told that you examine ulnar nerve only. But as a student, he will examine the other nerve also. He might not present it, but he will.
Yeah, that's a tricky situation. Maybe we can always extend. See, the question is when they have 2 nerve examinations and when you want to really assess the candidate knowledge on anything, it comes to diagnosis is not a problem in 2 nerves. It is a problem of treatment. If median and ulnar are gone, there are no tendons available to transfer. So how are you going to reconstruct his hand? So that's where his knowledge and the principles will come, because You may have to do static procedures, you may have to do bony procedures, you may have to fuse the wrist. So that's the where one question, if he answers, that is enough to give him a distinction.
Thank you.
Thank you.
And Dr. Ray and Dr. Shah, I think they are not here. Okay, I think we had a very good. Dr. Ray is there. Dr. Ray, anything you want to?
Very common question we ask: show me the autonomous zone of median nerve and autonomous zone of ulnar nerve. Dr. Reddy has shown beautifully, but the thing is that I have seen one slide. It has come up to the base of the ulnar, proximal phalanx. So
that slide, I'll put it back again. See, it is basically there is no actually correct is terminal phalanx of little finger. But some books, especially the Sutherland, has extended it up to middle phalanx of little finger, not proximal phalanx.
Distal phalanx.
Distal phalanx of index.
One more question we ask: whether EMG is a must in delayed case of nerve injury. EMG is a must or not? Okay.
So now,
the students have answered.
No, that's what. So usually we ask the students, like if you are asking for an EMG, I usually ask them, what do they expect of the EMG report? Like if I say I order for hemoglobin, I want it to be within certain range. So if you order for an EMG, so if the student answers, I want to see a late case, whether the fibrillation potentials are there, or the fibrillation potentials are not there, to know whether the recovery is there or not. I think that is enough for us to pass them, because ENMG is too complicated to go into more details for a. So if it just says the ENMG tells us whether it is re-innervating or not re-innervating, that's, I think, should be satisfactory.
Yeah. Anything else? I think Dr. Shah is not there. Thank you, Dr.
Gopalan, there are no questions from the audience. I think we can move forward.
Okay. Okay, then we'll go to the last speaker of the day, and from the upper limb, we go to the lower limb. Dr. Sunit, he will be presenting as a case of common peroneal nerve injury. Dr. Sunit, over to you.
Okay. Yeah. So I think most of the things in the peripheral nerve injury has been covered. So I would rather like to focus on the localized common peroneal nerve palsy, where probably I think what exactly is the problem with that nerve palsy, and rather avoid the generalized aspect. So I think before moving into any short cases, I think the short cases time allotted is not very long. So I think any students who is appearing for the getting a short case like common peroneal nerve palsy should actually have some idea in his mind of what can be the causes of this common peroneal nerve palsy. I think in addition to the exact site of common peroneal nerve palsy, the other injury like sciatic nerve lesion or some sort of lesions in the totally peripheral, where the sciatic nerve can also be palsy, or any ruptured disc, and also leads to mimic this sort of common peroneal nerve palsy. So that things the students has to remember that what are the common causes and what are the other pathologies which can mimic the common peroneal nerve palsy. I think coming to the other causes of common peroneal nerve palsy, it can be the direct injury, like incisor penetrating injury in the at the level of neck of the fibula or just above it, or maybe some indirect injury due to fracture and dislocations of the lateral condyle of tibia, or the fractured neck of the fibula, or there is dislocation of the knee, or any compound fracture in the proximal part of the tibia. The other cause that iatrogenic case, which are not that common, so maybe the high tibial skeletal traction, or a tight plaster around the knee, high tibial osteotomy, or during the total knee replacement. Okay, and the other causes just above it, maybe the fracture shaft of the femur and various others, which already discussed. In addition to all these, I think there are a lot of generalized cause of nerve palsy, which also might mimic sort of common peroneal nerve palsy. So we need to have some idea regarding those also, because you need to examine the other limb also to exclude these generalized causes. And coming to the mainly symptoms, I think the common peroneal nerve palsy usually gives you a very, straightforward diagnosis, because the patient will typically, when patient comes in walking into your clinic, you will be able to diagnose the probably this patient has the common peroneal nerve palsy. The patient usually presents difficulty in lifting the foot, and patient usually comes dragging the foot on the floor as he walks, because the dorsiflexion is completely absent usually, and you can see the patient slapping the foot down with each step. Whenever the patient put one step forward, you will see that probably the entire foot is slapping on the floor rather than touching the heel first, and it's raising. Patient will rise the thigh to lift the foot, and there will be pain and weakness and numbness in the foot as well. As far as the signs of the common peroneal nerve palsy, there will be the cutaneous sensation will be impaired over the lateral aspect of the lower leg and ankle. As you can see here, this is the area where the supply is by lateral superficial peroneal nerve, and this is the deep peroneal nerve. The first ray is only supplied by the deep peroneal nerve. So these areas will be, the sensation will be impaired, and there will be reduced dorsiflexion and eversion of the foot and toe, and toe extension will also be absent, and the patient will be compensated by having a high stepping gait. And there will be however, if you carefully examine the patient's inversion and plantar flexion, this should be normal, because those muscles are mainly supplied by your tibial nerve. So you need to palpate the tibialis anterior tendon like this also. You can see whether those tibialis anterior extensor hallucis longus and the others, extensors of the toes are functioning or not. Those examinations are very important, and you need to ask the patient to push against the force, do the outward and inward to check for the inversion and eversion. And once you see the patient walking, you will be able to see that the patient's gait will be a foot drop gait, as it is high stepping. As patient tend to lift the thigh first, then lift the entire foot first, and then when patient put the foot ground, the entire foot comes down simultaneously, because it will slaps the foot on the ground as if, and so it's not the classical heel touching first. So I think the common peroneal nerve diagnosis is mainly clinical. So that if you want to do an investigation, these are mainly to support, like X-ray. If you want to do, I think it's mainly to rule out any indirect causes like fracture in the tibia, fibula, or ankle joint. And USG is usually very rarely indicated, and MRI is also very rarely indicated, in particular in some tumor situations or compressive mass lesions. MRI can be of some use. And nerve conduction studies can actually confirm the type of neuropathy and establish the site of lesion. So it may be of some helpful. Medical legally also you need to document this. So probably I would rather advocate a nerve conduction study, and it can also estimate the extent of injury and provide some prognosis. So I think if you keep on doing in the follow-up also, you will probably have some idea regarding whether the nerves are recovering or not, in addition to your Tinel, classical Tinel sign, what we tend to see most of the times. As far as the treatment is concerned, treatment depends on the underlying causes. I think if the cause is like pressure, any tumor which is pressuring on the tumor, if you remove those pressure, these tend to recover very fast. So I think the other medical treatment can, you can use or mainly to alleviate the painful paresthesia, and for that amitriptyline or pregabalin can also be used. I think the other thing which you can use is assisted and adaptive device like canes, crutches, or walker. This may be used to prevent the patient from falling, because the patient might have a difficulty getting gait, and to normalize the gait pattern, or to unload a painful weight-bearing limb. Ankle foot orthosis to support the foot in lightweight brace and shoe insert, so that patient's walking can improve. And you need to advocate some of the exercises also to strengthen the muscles and to regain or maintain the range of motions. And electrical functional stimulation, we already discussed, may sometimes help. I think surgery is usually done only if the conservative management fails, and I think like any peripheral nerve injuries, the surgeries you can divide into repair or decompression of the damaged nerve, or you can discuss about the fusion of the foot and ankle joint to prevent any further deformities, or you can do some tendon transfer for the stronger leg muscles. I think points should be which need to be considered before doing any surgeries to age of the patient, what is the status of the joint, whether they are more supple or there is any stiffness or deformity is developing in the joint, what are the muscles which are available for the tendon transfer, what is the condition of the other skin and soft tissues which are there, and what are the bony changes, any severe osteoporosis or any bony deformity is developing or not. So I think tendon transfer, the objective is to usually provide the active motor power to the paralyzed muscles, I think, and to eliminate the deforming effect of the muscle. Antagonist paralysis, you want to elevate the too much effect of antagonist muscles, and you can improve the stability by improving some sort of muscle balance around the time. I think tibialis posterior is most commonly transferred, and there are various ways of tibialis transfer described by the various authors. So you can transfer the anterior tibialis tendon to the second and third cuneiform, or you can also transfer to the modified cuboid transfer. And in Ober's technique, the tendon is passed to the anterior compartment of the loo, and classically when it's transferred into the second metatarsal, or you can also do some split transfer. Those are the much details about the tendon transfer, which probably is not the main aim of this talk. And regarding the bony surgeries, I think the lumbar node arthrodesis is usually very commonly indicated in these sort of situations where the isolated equinus deformity is there for more than 10 years. So what you usually do is you take an X-ray in the full flexion, plantar flexion, and then you cut the talus and the upper part of the calcaneum so that you can make the 4-foot plantigrade at that level, so that any further plantar flexion does not happens. And triple arthrodesis is usually most effective when the age is more than 12 years, where you need to fuse the subtalar joint, calcaneocubitus joint, and talonavicular joint. And ankle arthrodesis can also be done, I think, some in severe paralytic equinus deformity in adults. I think if you combine it with the subcutaneous plantar fasciotomy and lengthening of PA, it's usually described as the bar and bone, usually gives you the reasonably good results. I think that's in a nutshell about how you need to examine and you need to manage your common peroneal palsy in details.
Thank you, Dr. Sunit. Among the lower limb, one of the common cases we get is lateral pulmonary nerve palsy. Of course, sometimes if you don't have that, you get sometimes sciatic nerve also. And very nicely covered. Dr. Darshan, anything more to be added?
Timing of this thing, when common peroneal, that is one more thing which this thing, it was very nice. I think that is one thing which they get confused. What is the cause of the injury? So if it is higher up, we might have to wait for some more longer, because if it is secondary to hip dislocation, so you might have to wait for much more longer period, or if it is around the knee, much more shorter duration. So 6 months to 1 year at least, they might have to, they will have to use. And a lot of questions for students is they will definitely ask about splints whenever a foot drop question is there. So even if you know about this, the students have to be aware of the question will get diverted. You might have prepared for all the tendon transfer also, but they'll catch you in splints, orthosis, they'll ask you. That is one thing.
Dr. Reddy?
So the usual question, most of the time we have a foot drop case because of a posterior dislocation of hip and the sciatic nerve compression.
Okay.
Usual question we ask the student is, why is there only foot drop and not the total sciatic nerve palsy? I think everybody asks that.
Very common question.
A very common question. So there's a lot of confusion in these things. I give the standard explanation is the sciatic nerve, the lateral popliteal nerve component is purely motor. So the axons are thicker, so they are more prone for injury than the posterior tibial nerve. Otherwise, there is no specific explanation why it should come. So this usually, because most of the time we have foot drop with some old unreduced posterior dislocation.
Yeah, I think
this is the explanation I always give to my students to tell in the exam.
That's one of the reasons. Second reason is the anatomical.
All on the periphery.
Sorry?
Yeah.
Yeah, the anatomical configuration of the nerve, these are the lateral common peroneal component gets more often involved because that is the one closer to the injury area. Usually if it is traumatic, that suppose your sciatic nerve gets cut, that's the area which is cut. That's one of the reasons. Vinit?
That's the reason. That reason what I was trying to search what the explanation what they say, like the radial nerve palsy is common with shaft humerus because of the stretch, and it's a pure motor, mostly motor, so they more prone for injury. Similarly, the stretch injury in sciatic nerve, the lateral popliteal nerve component is first, which will get most affected. So that will be. The another, I think, in every foot drop case, I think in every exam, inevitably the examiner will ask to demonstrate one muscle power. So all the muscles supplied by lateral popliteal nerve, the student should know exactly how to show the power in the muscle. I think they need to practice that, because I think inevitably every exam they'll ask one muscle. They say demonstrate the power of peroneal. So they should know how to position the limb, what to ask, and how to show the power. I think that they need to practice.
Another thing was this: when you do a tendon transfer for a foot drop, it's an anti-gravity muscle. So after some time, does it become weak? It doesn't work.
No, sir.
No.
No, it doesn't become weak.
Doesn't have a problem like
If
that.
you secured it well, it doesn't become weak.
Dr. Vineet,
Sure.
anything?
Vineet has something to add on the reason for CPN in a sciatic nerve stretch. He has that favorite question.
Yeah, Vineet.
As they are just hypothetically, being taught from generations to generations, and I don't know if textbooks will answer that. More peripheral placement of the CPN fibers, and they are phylogenetically more fibers.
Vineet, your voice is breaking.
Voice is breaking.
So he's telling basically it's all arranged peripherally on the of the sciatic nerve. That's why
The anatomical.
yeah.
Oh, Vineet has 5 explanations. Let us hear to him.
My God. Yeah, Vineet.
Please, Vineet.
Anatomical variations are there.
The voice is not clear. It's breaking.
A lot of echo, Vineet.
I think some phone, if it is on, could switch off the phone.
Yeah.
Because the common peroneal nerve roots, they come from a separate root in the sciatic nerve.
I'm sorry, my headphone just switched off, so my voice will take some time. I think let's move on to somebody else.
So there is some concept of the vascularity of the bundles also, and there is another concept that the CPN part of the nerve is caught between 2 bony points, meaning the neck of the fibula and the sciatic notch. We've already talked about the peripheral arrangement, and we've already talked about the motor component. Some people, okay, Vineet is here. Vineet, go on.
I think the reasons which were taught to us were the peripheral arrangement and the fact that it is more fixed as compared to the tibial component. And phylogenetically, they are newer fibers, the vascularity being different. But as already has been told by the seniors, I think the most important ones would be the type of fibers. They are motor fibers. But somewhere I feel that the nerve being fixed, the CPN component being fixed between 2 points, is we know that stretch affects nerve which has lesser length. So probably that may be the reason, although it is very difficult to pinpoint one.
Something on the type of fibers, the A-type fibers.
Yeah, that I think already was covered.
Yeah.
My question, Vineet, what should the student answer if this question is asked? One answer what he can give so that he'll pass.
There are various reasons.
You all the answers.
It's like we give all these things and confuse the examiner itself. What you want to say.
I'm not sure. I think these reasons are sprayed out in different textbooks, and since the jury is still not out, you can just say that this is a common occurrence. There are various reasons proposed by different authors, and the various reasons are such. And I think what Dr. Reddy said should come first. The type of fiber, the motor fibers, that is the most accepted sort of thing. Then the peripheral arrangement, and then the vascularity, and then the fixity.
So I always, when they answer that fibers, the answer, I just stop at that level. If it goes beyond that, maybe. But I think the students need to answer at least one correct, probable explanation, so that they know that the lateral component is more involved than the sciatic, than the posterior component in sciatic nerve injury.
Sandeep, anything to add?
Yes, sir. Wonderful discussion going on, and endless discussions these can be, because there can be many more questions coming up. I think 2-3 very important questions, the basics which we ask to the PGs are, what are the causes of? Okay, in that comes, what are the iatrogenic causes? We can think injuries, but what are the basic causes? So it can be while putting some skeletal traction, it can injure. While putting a skin traction, it can injure. Because of the plaster application, it can injure. So all these things also need to be taken care of. That what are the iatrogenic causes? We should not do any harm to the patient. So the basic thing is that. Second, we should be able to differentiate how to illustrate or demonstrate a high lesion and a low lesion in a common peroneal nerve. So I think that is also an important. I think if Dr. Sunit can just shed some light that what tests to be done.
I mean, the deep peroneal nerve is usually supplied in the anterior compartment of the tibia. So if you look into the common peroneal nerve palsy, where dorsiflexion is preserved, deep peroneal nerve is preserved, probably you will say it's a low peroneal nerve palsy, where the peroneal nerve palsy has occurred after its bifurcation. The deep peroneal nerve has already gone into the anterior compartment and it's functioning, so probably it's a low peroneal nerve palsy, and if both the components are gone, probably it's called the high peroneal nerve palsy. I think probably the high peroneal nerve palsy is probably more common. We see, we very seldom see the isolated low peroneal nerve palsy where the peroneal compartment is only paralyzed.
One other question, usually the foot drop cases, when they have this thing, they usually, sometimes the student gets confused between a VIC, especially VIC when it is a posterior compartment is widely involved. So they will have loss of dorsiflexion and there's some loss of sensation is there. So sometimes the student gets confused. So they need to selectively examine all the group of muscles before they can find out. This is one of my observations.
How common is the neuropraxia of the common popliteal nerve? Do you see it? Basically, it's not common, isn't it?
Yeah.
Compared to, we had, these, particularly in the south, the olden days, the blacksmiths, they sit in the squatting position and do that. They don't sit. So for sometimes, malaria system, they sit for a long time. Once I had a bilateral component of palsy because extreme flexion, knee flexion, hip flexion, they sit and squat. So that's supposed to be, it is given that postural this thing can occur, but it's not common. I don't know, I forgot anybody. Dr. Ray, anything you want to add? I don't think.
No, about the examination point of view, when we deal with the foot drop because of the common peroneal nerve injury or something, definitely examiner will ask about what are the other causes, particularly in our country, Hansen's disease will come definitely, and they will ask some questions about that. And second issue is that the orthosis in foot drop, common peroneal nerve, the orthosis, common orthosis, what is recommended, that will be asked. So students should be prepared for that, the orthosis in foot drop.
How common is it? Our days, leprosy, Hansen's and foot drop was, if it was a short case for me in my diploma. It used to be very, very common. How common is it? In some endemic areas are there, but generally speaking.
Sir, no, not so common, sir.
Not so common.
Not so common, but it is also common because if you go through the Indian national statistics, there are a lot of patients of Hansen's in our country.
They are limited to endemic areas, I think, because when I talk to PGs, most of them have not seen a Hansen's at all.
But there are, sirs.
There are.
Because the national statistics shows like that.
No, yeah, they're limited to villages and things where there are no adequate, because the treatable conditions. Definitely it has come down compared to those days.
Mm-hmm.
Okay. Anyway, that's a good thing.
Few more questions can I ask?
Yeah, sure, of course.
So Dr. Ray had suggested that we should make OSCE for PGs. So I have made one OSCE for foot drop case.
Sorry.
So I will only tell the questions. The PGs can note it down. high stepping gait can be seen due to which peripheral nerve injury? Why is common peroneal nerve component more often involved in a sciatic nerve stretch? Causes of common peroneal nerve injury. Prerequisites of tendon transfer in a foot drop patient. What orthosis can be prescribed in a foot drop patient?
Very good.
And muscle supplied by common peroneal nerve in sequence of division of branches.
Sequence of innervation.
Yeah. So foot drop is a very difficult case because there is very little there in the case. So invariably the student will miss out that there is an equinus contracture, and he will go ahead and say that I will do a tendon transfer.
So deformity should be eliminated.
So that will take him to a question of what is the prerequisites. So when he comes to prerequisites and they will ask him what is the power of the tibialis posterior, now it was a sciatic nerve injury in which the CPN has not recovered. So suddenly when he is asked to demonstrate, the tibialis posterior is also weak. So now he's terribly stuck. There was nothing to be seen in this patient, and now he is terribly stuck with a equinus contracture and a weak tibialis posterior.
This happens quite often, sir. This happens quite often in the exam.
Yes.
That the tibialis posterior will be 2 or 3, and the student don't examine the muscle power of the muscles which they are going to use for transfer.
They forget to examine the posterior tibia.
Dr. Ray, how much should the PG know about orthosis for foot drop? Should he be able to prescribe it? The old traditional way of AFO with anterior assist and posterior heel block.
Yeah.
Dr. Ray?
Yes, sir.
About orthosis in foot drop, how much the PG should know?
Nowadays it is spring device is there. Okay. And foot ankle orthosis, KFO is commonly prescribed, and sometimes we also prescribe this flow reaction orthosis, FRO.
So you mean he should know about static as well as dynamic devices?
As well as dynamic. Both should know about it. That should be prescribed.
Nowadays what if...
For reaction orthosis, the principle they should know how it works. That's what we expect them to know, the principle of FRO.
Nowadays, they don't concentrate much on orthosis because we used to have posting. They don't have a posting. So they just 1 or 2 lines. They say a foot drop splint or something and they stop with that. You don't go into details also, frankly speaking.
No, foot drop preventing shoe is available. That is as a spring device, and that keep the foot always dorsiflexed. Okay.
Dynamic splits.
Dynamic.
The use of orthosis also decreased. I think earlier, I think there were no treatment were offered to those patients, so the orthosis were quite common in those patients. Probably, I don't think we can blame students that much that they don't know too much about orthosis, because they don't tend to see the patient having orthosis for too much. The patient tends to get operated of ankle fusion and everything, and has been done. So I think probably, and the cases are also decreased where you have a common peroneal palsy for too long. The nerve transfer and everything has made the chronic disability much less, I think.
No, very true, Sunit. Not only that, they don't prescribe. They refer to the physiotherapy or rehabilitation department. That's another reason. They can't prescribe because there's a separate section for that, and that fellow would like you prescribe.
Exactly.
Manish, anything more? Any questions are there? Anything more from the audience?
No questions.
Okay. I think then I thank, first of all our faculty, invited faculty, Dr. Darshan, Dr. Sunit, Dr. Vineet, Dr. M. Reddy, all of you for, missing the IPL and staying with us.
Thanks for the opportunity, sir.
So it was very, very nice, very informative, and very useful because this is the thing really a common case in the exam. So very useful for the postgraduates. I'm sure they will see it again and again and learn it. Then to Dr. Lalit and Sandeep, even if they were not guest faculty, they were the ones who are always here. Dr. Lalit, particularly, I remember very active participation, which is very, very important. That's just really how a program can go up, how they will learn. And he has always got questions which are very, very appropriate. And thank Dr. all my colleagues, Dr. Ray and Dr. Shah, Manish and